Pariante, who's from King's College London. And this will be an update of an MRC-funded project, which is persistent fatigue induced by interferon-alpha, a novel inflammation-based proxy model of CFS-ME. So thank you very much, Professor Carmine.
Thanks, Chris. Oh, sorry, I need one more second. Okay, I'm on. Well, good morning, everybody. I want to thank, of course, this organization for having me speaking here again, as I did last year, and Sonia for the wonderful organization, and Chris for chairing the session and the day today. What I want to do is give you what is the final update on the project that we have been conducting over the last few years, funded as part of the MRC, the initial MRC initiative. Some of you who have been here before may have heard preliminary analysis of this, but this is the final version, which is now submitted for publication and in fact quite close to acceptance. Now, the data try to address the overall questions of the potential role of immunity and activation of the immune system in the context of chronic fatigue syndrome and ME. But, and I will show you the model in a second. Well, in order to address some of the shortcomings of the research that has been conducted in CSF-ME until now, partly because of the nature of the disorder per se, as I will discuss in a second, this research brings in, together with patients with a clear diagnosis, also a model of for the development of chronic fatigue syndrome that, as all models have, of course, its limitation, which is the people who are subjected to an immune activation because of therapeutic reason, because they take a course of therapy with interferon-alpha, which is a major cytokines which is used routinely, or at least was used routinely until recently in the treatment of hepatitis C. So I'm going to present data both on these models and on patients with chronic fatigue syndrome, ME, and try to draw as much as possible of what we can understand from this model. Now, we know that there is at least evidence of some involvement of the immune system in chronic fatigue syndromes, ME. We all know that fatigue is a classical symptoms of people who have an acute state of infection or they're having an inflammatory disorders. We know from epidemiological studies that infective agents often triggers CSF-ME. The evidence of actually higher inflammation at the time that people have a clear diagnosis and perhaps reach at the clinical studies or research studies is perhaps less strong. I mean, of course, there have been some studies showing 1 or 2 immune abnormalities, but certainly compared to what would be the profile of a classic immune disorders, the profile at the time in which the illness is established is certainly not as strong or not as evident as in other disorders. So, but there's certainly hints that allow us to kind of wanting to investigate more this field. So what is the main problem? From a research point of view is that, of course, once we involve in research individuals with a diagnosis of chronic fatigue syndrome or ME, they have already probably suffered from fatigue for many, many months, if not years. And certainly all the process that has been going on between the beginning, whatever was the initial cause, and the consolidation of symptoms months or years later is missed in the research assessment. And this is partly due to it's actually due to the difficulty of knowing who will or who will not develop chronic fatigue syndromes, and really the impossibility of just assessing prospectively such a large population that we would eventually be able to pick up just by chance people that develop chronic fatigue syndrome. So we are using this interferon-alpha as a model because allow us to examine people before they have the immune triggers during the immune triggers and after the immune triggers. Now, this will give even better ideas of the models and also allows you to compare what happens if you think about chronic fatigue syndrome. Let's think about chronic fatigue syndrome, and let's think about chronic fatigue syndrome, especially in association with an infective triggers or an immune activation trigger. So you have a healthy state on which many of us would have no reason to be in contact with any research study or any clinical services, or there would be no way of measuring anything at that stage. Then there is an immune trigger. So this could be an infective episode, for example. And at this point, some studies had been conducted, starting around this time. And then at some point, either with or without a recovery time, some people would develop the acute fatigue that characterized the infection or any other immune trigger would develop into chronic fatigue. We would, in the normal course of chronic fatigue, we would miss this assessment really, we would miss, all this initial assessment here. So with interferon alpha, we can mimic, I know this is not the same thing, that is not the same disorder, but we can mimic this course of the illness because we know exactly who and when they will start interferon alpha, so we can assess them here, something which we cannot do in patients who develop chronic fatigue syndrome. We can assess them during the immune triggers. Now, this is a 6 to 12 months duration, so it's a profound, persistent activation of the immune system, equivalent to a really sustained infection or a sustained inflammatory disorder. Then, with interferon alpha, we allow people, of course, stop the treatment, and we allow 6 months of time to recovery. During this time, most people, but not all of them, most people that has developed acute fatigue during the treatment will recover to baseline level, but around 30%, 6 months after the interferon alpha has been stopped, so when there is no immune activation anymore, they still have persistent fatigue. And we think that those 30% can allow us to understand at least some, give us hints and understanding that could be translated, at least in part, to pathogenesis of chronic fatigue syndrome. So this was a long introduction, just really to kind of explain why we've decided to use this model. What can it tell us more than just comparing patient and controls when the illness is established? So, as I said, the study aims at exactly this. Use interferon alpha induced persistent fatigue, so fatigue that is present when there is no longer any immune activation, to understand if similar processes may occur also in the context of chronic fatigue syndromes. So in the original sample, we had 55 patients. I also want to say that this study cannot be done anymore, unfortunately, because interferon alpha has now become obsolete in the treatment of hepatitis C. So if we want to either replicate these models or try to understand more about it, we will have to think about something similar but different, just because hepatitis C is treated with other medication now. But we were lucky to literally to have been able to study the last few patients that had received this treatment. This is a problem worldwide, not only in the UK. So exactly as we expected, of the patients that started interferon alpha, 37 patients, so about 2/3, had resolved fatigue. So 6 months after they stopped interferon alpha, their level of fatigue were back to normal, or in fact they were better than normal, better than before, as you would expect, because they had hepatitis C virus that was cleared, so you would expect most of them to actually, of course, be better than when they when they started the medication. But 33% had persistent fatigue. So their fatigue level were worse than before even they started the interferon alpha treatment, which is actually paradoxical because, of course, they were clear from the virus, yet their quality of life, especially their fatigue, was worse than even before. So let me show you some data. This is fatigue. This is fatigue levels. Okay, so this is just measurement of the fatigue with a classic shoulder fatigue scale. And the two lines represent those who develop persistent fatigue and those who do not develop persistent fatigue. So if you look at the blue line first, these are the ones who recover. So these are, if you like, the subjects that have a healthy response. You can see here, so this is before starting interferon. This is 4 weeks, 8 weeks, 12 weeks, and 48 weeks, so 1 year of treatment. There is an initial increase of fatigue which persists. These are the 6 months without any interferon in which the fatigue recovers. And the level here is lower than at the baseline. So they are actually feeling better, as you would hope, as I said, than before starting the treatment. This, however, is the group that develop persistent fatigue. Their fatigue is much higher right at the beginning, remains elevated throughout the whole time, and even if there is a partial recovery, the recovery is not sufficient. And so as you can see at follow-up, so 6 months after they stop interferon, they are much worse than at their baseline. And this, as I said, is the group that we think can give us information about pathogenesis of chronic fatigue. Now, the first things I want you to notice in this figure is that at the real baseline, so before they started any treatment, there is no difference between these two groups of people. So there is no way, at least by just measuring fatigue, that we can immediately say, oh, you are someone at risk of developing chronic fatigue syndromes, and you are not. Or if people that, for example, have a higher level of mild fatigue are more at risk of having chronic fatigue syndromes compared to people that don't have that, at least using this model. And remember, this is a kind of assessment that would be impossible to make just in people that develop natural chronic fatigue syndromes. The key issue is this initial fatigue. So you can, if you want to translate this into chronic fatigue syndrome, ME, this would be the immediate reaction to, let's say, an infective episode, or an immune challenge, or a stressful episode. Because, of course, stress, even psychosocial stress, profoundly activates the immune system. And I will talk more about this later in the afternoon when I present a talk on the relationship between inflammation and the body in general. So something happened really, really early. And this seems to be the time that the trajectory starts. So early on is when we really need to try to understand what happened for people that, in reaction to normal events or events that other people also have, like an infection or a stressful event, develop fatigue. Now, what about the immune system? And let's keep this for sake of time. Well, we measure quite a lot of cytokines. As you know, the cytokines are measurable protein in the blood that tell us the state of the activation of the immune system. Two things we could notice. First of all, that the key findings are about interleukin-6 and interleukin-10. They are classic inflammatory cytokines, or they are classic signal of inflammation. Interleukin-6 is perhaps the most studied cytokines in the context of inflammation. Interleukin-10, which I will present in a second, is an anti-inflammatory cytokine, but is elevated during inflammation, probably because it's trying to compensate. Now, these are the two cytokines where we could clearly find the difference between those who develop chronic fatigue syndrome-like picture, so the persistent fatigue, and those who did not. And the key things, again, is this early increase of interleukin-6. As you can see, all patients that increase interleukin-6, that's normal because they receive this profound immune activation. But those who also, the red line are those who develop persistent fatigue. Their interleukin-6 shoot up much higher and remains higher throughout the treatment. Although interesting, and I'll talk a little bit more about this, the levels goes back to normal, so there's no longer any difference here. But certainly early on. Again, the notion that something happened early on, at a time where most patients that then develop chronic fatigue syndrome would have not been studied. The same thing with interleukin-10. This early increase over the first 4 weeks of treatment Look at this. These are the patients that do not develop persistent fatigue. Their fatigue goes back to normal. The interleukin-10 doesn't move at all. But for those who are sensitive to develop persistent fatigue, the interleukin-10 goes up, again, early on. But again, no difference to the follow-up. And I'm going to talk about this in a second. I'll skip this again for time. Okay, what happens at follow-up? So what we've done is that we've analyzed this group of people, also this time point here, of course. So this is the time that actually the persistent fatigue is present. We cannot consider them at any stage persistent fatigue before, because that's when the immune system is activated. Here is when there is no longer any immune system activation, there's no longer an immune challenge, and this is when the persistent fatigue is present. Okay? So we compare them, these two groups, at this stage here, and we compare them also with a group of healthy control and a group with chronic fatigue syndrome patient. And what we found is that, again, perhaps based on kind of consistent with what I mentioned before, that by the time there is chronic fatigue syndrome or the time there is persistent fatigue, there's no longer immune activation. So if you compare, this is interleukin-6, if you compare resolved fatigue and persistent fatigue, there's no difference in interleukin-6 anymore. This group here has much higher fatigue than this group, but there's no difference in immune activation. And look at this, the chronic fatigue syndrome group compared to healthy control group, also there is no difference. Of course, the level of fatigue here is by definition very high, but there's no difference in interleukin-6. Not only that, they have a much higher level of fatigue also compared to the persistent fatigue and the resolved fatigue. But again, the interleukin-6 is, if anything, lower. So confirming the notion that the measurable immune activation happens really early on, not when the phenotype, when the disorder, the symptoms are established. Exactly the same things happen with interleukin-10. Remember, interleukin-10 is the other cytokine that shoots up really high, only in those who later on develop persistent fatigue. By the time persistent fatigue is present, again, no difference between those with persistent fatigue and those with resolved fatigue, no difference between chronic fatigue syndrome and healthy controls. So I want to really kind of, again, emphasize this notion that perhaps is not that the immune system is not important for chronic fatigue syndrome. In fact, it may well be really important, at least for a subgroup of patients who develop chronic fatigue syndrome. It's just that we're missing the window to study the real abnormalities that occurs early on when something triggers the immune system, either, as I said, an infection or another episode of medical illnesses or an important psychosocial stressor that can activate the immune system. Another couple of points I want to make and then I'll finish. First of all, although there is a relationship between inflammation and depression, and I'll mention this later on in my talk in the afternoon, the depression and fatigue in this patient are different. So those people who develop persistent fatigue are not biologically similar to people who develop depression. Again, emphasizing that although there is some overlap, these are also depression and fatigue and chronic fatigue are different syndromes with different pathogenetic mechanisms. Most importantly, just by looking at cytokines, sorry, I present this and then I'll go back. Just by looking at cytokines, if you look at a patient that developed depression during interferon-alpha, there is no difference early on in interleukin-6. So this is a little bit of a complicated slide, but the key point is really this one here. That if you develop depression during interferon-alpha, or if you do not develop depression during interferon-alpha, there is no difference to interleukin-6 at week 4 or at week 24. So this time here, where those who develop fatigue are have much more inflammation, there's the same cytokine, which is elevated in those who become persistent fatigue, is not elevated in those who become depressed. So there is a clear biological separation from these two group of people. Also, classic risk factors for depression are not actually relevant to persistent fatigue. So, of the things that we looked at, that we try to understand that can predict development of persistent fatigue versus normal resolved fatigue, we couldn't really find any of the usual suspects. Age and gender, for example, were not important. Ethnicity were not important. Childhood trauma, so you're not really reading this. So exposure to stress early in life, which we know that in other contexts, and certainly in the context, for example, of fatigue in the context of medical disorder seems to be important, is not important in this context. Educational level, employment, relationships. So the classic psychosocial risk factors are really not important in this context. Again, differentiating very clearly fatigue from depression, and in general fatigue from the risk factors for fatigue from other common risk factors. What seems to be important is treatment duration. So the longer patients have been taking interferon-alpha, the more likely they are to develop persistent fatigue. Although the treatment is scheduled, some patients stop earlier for side effect or because the virus responds better, and so on. So there is a variability, and most of the variability is between 6 months to 18 months. Within that variability, those who have more interferon-alpha are more likely to develop persistent fatigue. Again, if you transpose this into chronic fatigue syndromes, ME situation, perhaps those who have a longer or more intense or both activation of the immune systems in response to whatever was the trigger for that person early on are those who will develop chronic fatigue syndromes rather than recover as other people may do. So I want to finish with this slide because this is really about the next steps. So what we really want to understand is what characterizes this group of people with persistent fatigue, and whether we can use this information to understand more about chronic fatigue syndromes. And most importantly, what is really abnormal in the immune system of these individuals? Why do they have stronger immune activation? Is the immune system sensitized already from, I don't know, maybe infections in utero or infection early on in childhood, and then when something happened in young adulthood, another infection or psychosocial stressors, the immune system reacts even more? Or is the whole body of patients with chronic fatigue syndromes that is more sensitive to the immune activation? So the IL-6 goes up, and then the mitochondria, the muscles, and all the other tissue respond more. These are the sorts of questions we can start to understand. But again, by bringing the focus early on, around the time of the triggers, it really means we need to find other ways of looking at groups of people that we can assess longitudinally, prospectively. And I want just to thank the MRC for the funding and the people that work on this project over the years. Thank you very much for your attention.